Diagnostic studies, plain films, plain x-rays of the skull may demonstrate fractures, osteolytic or osteoblastic lesions, radiolucent foreign bodies, or pneumocephaly. Plain films of the cervical, thoracic, and lumbar spine are used to assess for evidence of bony trauma or soft tissue swelling suggesting fracture. Spinal deformities and osteolytic or osteoblastic pathologic processes also will be apparent. However, the use of plain films has decreased given the rapid availability and significantly increased detail of computed tomography scans. They are typically used for assessing alignment in patients with known fractures, for intraoperative localization, and postoperative assessment of spinal instrumentation. Computed tomography. The non-contrast CT scan of the head is an extremely useful diagnostic tool in the setting of new focal neurologic deficit, decreased mental status, or trauma. It is rapid and almost universally available in hospitals in the United States. Its sensitivity allows for the detection of acute hemorrhage. Fine slice CT scanning of the spine is helpful for defining bony anatomy and pathology and is the method of choice for identifying fractures of the spine. By providing an assessment of spinal alignment, CT scans can provide an indirect assessment of ligamentous injury, for example, rule of Spence for assessing transverse ligament injury during Jefferson fractures. Conventional contrast-enhanced CT scan will help show neoplastic or infectious processes in the current era. Contrast CT generally is used for those patients who cannot undergo magnetic resonance imaging scanning due to pacemakers or metal in the orbits. Magnetic resonance imaging. Magnetic resonance imaging provides excellent imaging of soft tissue structures in the head and spine. It is a complex and evolving science. Several of, two describing, T1 sequences made before and after gadolinium administration are useful for detecting neoplastic and infectious processes. T2 sequences facilitate assessment of New York, Elsevier, Mosby. Lesion-associated edema in the brain and neural compression in the spine by the presence or absence of bright TT2 CSF signals. Fluid-attenuated inversion recovery imaging is a T2 sequence with suppression of the CSF signal so as to emphasize lesions and edema, particularly adjacent to the ventricles. Diffusion-weighted images is the gold standard for identifying ischemic stroke within 12 hours of symptom onset. Gradient echo sequences can be used to identify acute subacute blood products and are used to assess for microhemorrhages in traumatic. Magnetic resonance imaging. Magnetic resonance imaging provides excellent imaging of soft tissue structures in the head and spine. It is a complex and evolving science. Several of, two describing, T1 sequences made before, T1 sequences made before and after gadolinium administration are useful for detecting neoplastic and infectious processes. T2 sequences facilitate assessment of New York, Elsevier, Mosby. Lesion-associated edema in the brain and neural compression in the spine by the presence or absence of bright TT2 CSF signals. Fluid-attenuated inversion recovery imaging is a T2 sequence with suppression of the CSF signal so as to emphasize lesions and edema, particularly adjacent to the ventricles. Diffusion-weighted images is the gold standard for identifying ischemic stroke within 12 hours of symptom onset. Gradient echo sequences can be used to identify acute subacute blood products and are used to assess for microhemorrhages in traumatic diffuse axonal injury, amyloid angiopathy, and also in the diagnosis of cavernous malformations in the spine. Table 42-2. Short tau inversion recovery or FAT. Suppressed T2 sequences are useful for assessing for the acuity of fractures and identifying ligamentous injury. Non-invasive alternative for the initial screening assessment, CT and hysterangiography. Recent advances in CT technology, such as short acquisition times with multi-detector technology, has allowed for imaging of vascular anatomy. Fine slice CT scans can be combined with a time bolus of intravenous contrast in the arterial phase and venous phase to assess arterial and venous vasculature, respectively. Although traditional catheter-based angiography still serves as the gold standard, CTA and CTV provide short tau inversion recovery. Non-invasive alternative for the initial screening assessment and follow-up of patients with suspected or known vascular lesions, as well as the evaluation of vasospasm. Similarly, fine slice time-of-flight axial images can be reformatted in 3 dimensions to build MRI angiograms and MRI venograms. MRI angiograms can detect stenosis of the cervical carotid arteries or intracranial aneurysms greater than 3 millimeters in diameter. MRI venograms can assess the dural venous sinuses for patency or thrombosis. 2-dimensional time-of-flight imaging performs vascular reconstructions purely based on flow and does not require gadolinium contrast administration, CT, and Mr. perfusion. Perfusion scans have recently emerged as a method to a global assessment of the vascular integrity in the cerebral hemispheres, which is very important in the assessment of ischemic stroke. CT perfusion scans generate quantitative color maps that indicate various physiologic parameters such as cerebral blood flow, cerebral blood volume, and mean transit time through quantitative analysis of rapidly acquired image sequences during intravenous contrast administration. Similar to perfusion CT, perfusion MRI can be used to generate quantitative color maps of relative cerebral CBV and MTT. These perfusion-based measures can be used along with diffusion-weighted imaging in the evaluation of ischemic stroke, particularly to identify an ischemic penumbra or tissue that is ischemic but not yet infarcted and may be salvageable with intervention. Angiography. Transarterial catheter-based angiography remains the gold standard for evaluation of vascular pathology of the brain and spine. The current state of the art is biplanar imaging to reduce dye load and facilitate interventional procedures. Digital subtraction technologies minimize bony interference in the resultant images. Bilateral carotid arteries and bilateral vertebral arteries may be injected and followed through arterial capillary and venous phases for a complete cerebral angiogram. Electroencephalography. Electroencephalography involves measuring weak electrical signals from the brain that are transmitted through the skull through electrodes that are applied to the scalp. The voltage fluctuations detected by electroencephalogram are thought to reflect some membrane potentials from underlying brain tissue. Clinically, electroencephalogram is useful for detecting seizures, interictal markers of epileptogenic tissue, and widespread abnormalities in brain function, such as diffuse encephalopathy. Electroencephalogram is also used in concert with electrical stimulation to detect sensory evoked potentials that can be useful for intraoperative mapping during cranial and spine surgery. Electromyography and nerve conduction studies. Electromyography and nerve conduction studies are useful for assessing the function of peripheral nerves. EMG records muscle activity in response to a proximal stimulation of the motor nerve. NCS record the velocity and amplitude of the nerve action potential. EMG NCS typically is performed approximately 3 to 4 weeks after an acute injury, as nerves distal to the injury continue to transmit electrical impulses normally until degeneration of the distal nerve progresses. Invasive monitoring. The most reliable monitor always is an alert patient with a reliable neurologic examination. If a reliable neurologic examination is not possible due to the presence of brain injury, sedatives, or paralytics, or if there is active and unstable intracranial pathology, invasive monitoring is required. There are several methods of monitoring intracranial. Physiology. The methods described in the following sections are bedside intensive care unit procedures that allow for continuous monitoring. Both procedures involve making a small hole in the skull with a handheld drill. They generally are placed in the right frontal region to minimize the neurologic impact of possible complications such as hemorrhage. External ventricular drain. An external ventricular drain is also known as a ventriculostomy. A perforated plastic catheter is inserted into the frontal horn of the lateral ventricle. An uninterrupted fluid column through a rigid tube allows transduction of intracranial pressure. CSF also can be drained to reduce ICP or sampled for laboratory studies. Intraparenchymal physiologic monitoring. Intraparenchymal monitors can be inserted into the brain through a threaded post locked securely into a burr hole, commonly referred to as a bolt. A bolt allows ICP monitoring with a fiber optic pressure transducer, but it is smaller and less invasive than a ventriculostomy and may be associated with fewer complications, although the data do not clearly support this. Furthermore, a bolt can also be used to introduce probes to measure brain tissue oxygenation, brain temperature, and to perform microdialysis of parenchymal samples. However, the utility of these latter measures in clinical practice is still under investigation. Patients with severe brain injury due to trauma or aneurysmal hemorrhage may benefit from placement of these sensors, in addition to a ventriculostomy to drain CSF for control of ICP. Such monitoring requires 2 twist drill holes, which may be placed on adjacent or opposite sides of the head. Neurologic and neurosurgical emergencies. Raised intracranial pressure. ICP normally varies between 4 and 14 mmHg. Sustained ICP levels above 20 mmHg can injure the brain. The Monroe-Kelly doctrine states that the cranial vault is a rigid structure, and therefore the total volume of the contents determines ICP. The 3 normal contents of the cranial vault are brain tissue, blood, and CSF. The brain's contents can expand due to swelling from traumatic brain injury, stroke, or reactive edema. Blood volume can increase by extravasation to form a hematoma or by reactive vasodilation in a hypoventilating hypercarbic patient. CSF volume increases in the setting of hydrocephalus. Figure 42-2 demonstrates the classic CT findings of hydrocephalus. The addition of a lesion, such as a tumor or abscess, also will increase ICP, the pressure volume curve depicted in Fig. 42-3 demonstrates a compensated region with a small PV and an uncompensated region with large PV. In the compensated region, increased volume is offset by decreased volume of CSF and blood. Increased ICP can injure the brain in several ways. Focal mass lesions cause shift and herniation. Temporal lesions push the uncus medially and compress the midbrain. This phenomenon is known as uncal herniation. The posterior cerebral artery passes between the uncus and midbrain and may be occluded, leading to an occipital infarct. Masses higher up in the hemisphere can push the cingulate gyrus under the falx cerebri. This process is known as subfalcine herniation. The anterior cerebral artery branches run along the medial surface of the cingulate gyrus and may be occluded in this case, leading to medial frontal and parietal infarcts. Diffuse increases in pressure, figure 42-2. Head computed tomography scan demonstrating hydrocephalus. The third ventricle is widened and rounded. The anterior horns of the lateral ventricles are plump, and pressure-driven flow of cerebrospinal fluid into brain parenchyma adjacent to the ventricles is seen. This is known as transpendymal flow of cerebrospinal fluid. Philadelphia, PA, Elsevier, Saunders. In the cerebral hemispheres can lead to central or transtentorial herniation. Increased pressure in the posterior fossa can lead to upward central herniation or downward tonsillar herniation through the foramen magnum. Uncal, transtentorial, and tonsillar herniation can cause direct damage to the brainstem. Figure 42-4 diagrams patterns of herniation. Patients with increased ICP or intracranial hypertension often will present with headache, nausea, vomiting, and progressive mental status decline. Cushing's triad is the classic presentation of hypertension, bradycardia, and irregular respirations. Focal neurologic deficits such as hemiparesis may be present if there is a focal mass lesion causing the problem. Patients with these symptoms should undergo an immediate head CT and rapid neurosurgical evaluation. Initial management of intracranial hypertension includes airway protection and adequate ventilation. A bolus of mannitol up to 1 gram kg causes free water diuresis, increased serum osmolality, and extraction of water from the brain. The effect is delayed by about 20 minutes and has a transient benefit. Driving serum osmolality above 300 mosm is of indeterminate benefit and can have deleterious cardiovascular side effects, such as hypovolemia, that leads to hypotension and decreased brain perfusion. A ventriculostomy and/or craniectomy may be needed for definitive decompression. It is critical to note that lethargic or obtunded patients often have decreased respiratory drive. This causes the partial pressure of arterial carbon dioxide to increase, resulting in cerebral vasodilation and worsening of intracranial hypertension. This cycle causes a characteristic crashing patient who rapidly loses airway protection, becomes apneic, and herniates. Emergent intubation and ventilation to reduce PACO to roughly 35 mmHg can reverse this process. Figure 42-4, schematic drawing of brain herniation patterns. 1. Subfalcine herniation. The cingulate gyrus shifts across midline under the falx cerebri. 2. Uncal herniation. The uncus shifts medially and compresses the midbrain and cerebral peduncle. 3. Central transtentorial herniation. The diencephalon and midbrain shift caudally through the tentorial incisura. 4. Tonsillar herniation. The cerebellar tonsil shifts caudally through the foramen magnum. Initial management of intracranial hypertension includes airway protection and adequate ventilation. A bolus of mannitol up to 1 gram kg causes free water diuresis, increased serum osmolality, and extraction of water from the brain. The effect is delayed by about 20 minutes and has a transient benefit. Driving serum osmolality above 300 mosm is of indeterminate benefit and can have deleterious cardiovascular side effects, such as hypovolemia, that leads to hypotension and decreased brain perfusion. A ventriculostomy and/or craniectomy may be needed for definitive decompression. It is critical to note that lethargic or obtunded patients often have decreased respiratory drive. This causes the partial pressure of arterial carbon dioxide to increase, resulting in cerebral vasodilation and worsening of intracranial hypertension. This cycle causes a characteristic crashing patient who rapidly loses airway protection, becomes apneic, and herniates. Emergent intubation and ventilation to reduce PACO to roughly 35 mmHg can reverse this process. Figure 42-4, schematic drawing of brain herniation patterns. Brainstem compression. The posterior fossa requires special consideration because the volume of the posterior fossa within the cranial vault is small. Posterior fossa lesions such as tumors, hemorrhage, or stroke can cause mass effect that can rapidly kill the patient in 2 ways. Occlusion of the fourth ventricle can lead to acute obstructive hydrocephalus, raised ICP, herniation, and eventually death. This mass effect can also lead directly to brainstem compression. Symptoms of brainstem compression include hypertension, agitation, and progressive obtundation, followed rapidly by brain death. A patient exhibiting any of these symptoms needs an emergent neurosurgical evaluation for possible ventriculostomy or suboccipital craniectomy. This situation is especially critical, as expeditious decompression can lead to significant functional recovery. Stroke. Patients presenting with acute focal neurologic deficits at a clearly defined time of onset must be evaluated as rapidly as possible. An emergent head CT scan should be done. The study is often normal because CT changes from ischemic stroke may take up to 24 hours to appear. A patient with a clinical diagnosis of acute stroke less than 4.5 hours old without hemorrhage on CT may be a candidate for thrombolytic therapy with tissue plasminogen activator. When a proximal large vessel obstruction is suspected, patients should be evaluated. Figure 42-5. Maturing cerebellar strokes for endovascular mechanical thrombectomy. If therapy can be initiated within 6 to 8 hours of symptom onset, intravenous TPA should be given regardless, but a non-invasive intracranial vascular study, such as CT angiography, should also be obtained in these cases. An emergent MRI is helpful, but not always diagnostically necessary. Seizure. A seizure is defined as an uncontrolled synchronous organization of neuronal electrical activity. A new onset seizure often signifies an irritative mass lesion in the brain, particularly in adults, in whom tumors commonly present with seizure. Patients with traumatic intracranial hemorrhage are at risk for seizure. In addition to airway and ventilatory problems, a seizing patient is also at risk for neural excitotoxicity if the activity is prolonged, such as in status epilepticus. Any patient with a new onset seizure should have imaging of the brain after the seizure is controlled and the patient is resuscitated. Trauma. Trauma is the leading cause of death in children and young adults, however. The incidence of death and disability from trauma has been slowly decreasing. This decline is partly attributable to increased awareness of safety devices such as seat belts and motorist helmets. Nonetheless, trauma remains a major cause of morbidity and mortality, and it can affect every major organ system in the body. The three main areas of neurosurgical focus are traumatic brain injury, spinal cord injury, and peripheral nerve injury. Head trauma, Glasgow Coma Scale score. The initial assessment of the trauma patient includes the primary survey, resuscitation, secondary survey, and definitive care. Neurosurgical evaluation begins during the primary survey with the determination of the GCS score for the patient. The GCS is determined by adding the scores of the best responses of the patient in each of three categories. The motor score ranges from 1 to 6, verbal from 1 to 5, and eyes from 1 to 4. The GCS therefore ranges from 3 to 15, as detailed in Table 42-2. Tracheal intubation or severe facial or eye swelling can impede verbal and eye responses. In these circumstances, the patient is given the score of 1 with a modifier, such as verbal 1 trillion, where T equal to 2. Scalp injury. Blunt or penetrating trauma to the head can cause injury to the densely vascularized scalp, and significant blood loss can result. Direct pressure initially controls the bleeding, allowing close inspection of the injury. If a simple laceration is found, it should be copiously irrigated and closed primarily. If the laceration is short, a single layer, percutaneous suture closure will suffice. If the laceration is long or has multiple arms, the patient may need debridement and closure in the operating room. With its superior lighting and wider selection of instruments and suture materials, careful reapproximation of the galea will provide a more secure closure and better hemostasis. Blunt trauma also can cause crush injury with subsequent tissue necrosis. These wounds require debridement and consideration of advancement flaps to cover the defect. Skull fractures. The usual classification system for bony fractures may be applied to the skull. The fracture may be characterized by skull X-rays or head CT. A closed fracture is covered by intact skin. An open or compound fracture is associated with disrupted overlying skin. The fracture lines may be single, multiple, and radiating from a point, or multiple, creating fragments of bone. Closed skull fractures do not normally require specific treatment. Open fractures require repair of the scalp and operative debridement. Indications for craniotomy include depression greater than the cranial thickness, intracranial hematoma, and frontal sinus involvement. Skull fractures generally indicate that a significant amount of force was transmitted to the head and should increase the suspicion for intracranial injury. Fractures that cross meningeal arteries can cause rupture of the underlying vessels and subsequent epidural hematoma formation. Depressed skull fractures may result from a focal injury of significant force. The inner and outer cortices of the skull are disrupted, and a fragment of bone is pressed in toward the brain in relation to adjacent intact skull. The fragment may overlap the edge of intact bone, or it may plunge completely below the level of adjacent normal skull. The inner cortex of the bone fragments often has multiple sharp edges that can lacerate dura, brain, and vessels. Craniotomy is required to elevate the fracture, repair dural disruption, and obtain hemostasis in these cases. However, fractures overlying dural venous sinuses require restraint. Surgical exploration can lead to life-threatening hemorrhage from the lacerated sinus. Traumatic subarachnoid hemorrhage in the Sylvanian fissure. Fractures of the skull base are common in head-injured patients, and they indicate significant impact. They are generally apparent on routine head CT, but they should be evaluated with dedicated fine-slice coronal section CT scan to document and delineate the extent of the fracture and involved structures. If asymptomatic, they require no treatment. Skull base fractures requiring intervention include those with an associated cranial nerve deficit or CSF leak. A fracture of the temporal bone, for instance, can damage the facial or vestibulocochlear nerve, resulting in vertigo, ipsilateral deafness, or facial paralysis. A communication may be formed between the subarachnoid space and the middle ear, allowing CSF drainage into the pharynx via the eustachian tube or from the ear. Extravasation of blood results in ecchymosis behind the ear, known as battle sign. A fracture of the anterior skull base can result in anosmia, CSF drainage from the nose, or periorbital ecchymosis, known as raccoon eyes. Copious clear drainage from the nose or ear makes the diagnosis of CSF leakage obvious. Often, however, the drainage may be discolored with blood or small in volume if some drains into the throat. In indeterminate cases, it is important to consider radiographic findings on the CT scan near the fracture that suggest CSF leak, such as pneumocephalus, subarachnoid, or intraparenchymal blood at the fracture site. The HALO test assesses for a double ring when a drop of the fluid is allowed to fall on an absorbent surface, but it has been shown to have poor clinical utility. The fluid can be sent for beta-2 transferrin testing, a carbohydrate-free isoform of transferrin exclusively found in the CSF. However, these tests often take 1 to 2 weeks to result and also can be difficult to incorporate into clinical practice. Many CSF leaks will heal with elevation of the head of the bed for several days. An elevation of the head of the bed reduces the hydrostatic pressure of the CSF fluid column in the cranial vault, near the site of the defect. As such, when the CSF leak is in the lumbar Thiehaus sac, the head of the bed should be flat, so as to maximize hydrostatic pressure of the CSF fluid column at the cranial vault, away from the site of the defect. In addition, lumbar drain can be used to reduce CSF pressure. When there is a contraindication to lumbar drain placement, an extraventricular drain should be used for CSF diversion. Although persistent CSF leaks have been When there is a contraindication to lumbar drain placement, an extraventricular drain should be used for CSF diversion. Although persistent CSF leaks have been shown to increase the risk of meningitis, there is no evidence supporting the use of prophylactic antibiotic use for preventing meningitis in patients with CSF leaks. Traumatic cranial neuropathies generally can be managed conservatively, with documentation of the extent of. When there is a contraindication to lumbar drain placement, such as an intracranial mass lesion or hematoma, an extraventricular drain should be used for CSF diversion. Although persistent CSF leaks have been shown to increase the risk of meningitis, there is no evidence supporting the use of prophylactic antibiotic use for preventing meningitis in patients with CSF leaks. Traumatic cranial neuropathies generally can be managed conservatively, with documentation of the extent of impairment and signs of recovery. Patients with traumatic facial nerve palsies may benefit from a course of steroids, although their benefit is unproven. Patients with facial nerve palsy of abrupt onset who do not respond to steroids within 48 to 72 hours may be considered for surgical decompression of the petrous portion of the facial nerve. Patients also may present with delayed onset facial nerve palsy. Again, steroids are used and surgery can be considered with mixed results. Closed head injury. Patients with facial nerve palsy of abrupt onset who do not respond to steroids within 48 to 72 hours may be considered for surgical decompression of the petrous portion of the facial nerve. Patients also may present with delayed onset facial nerve palsy. Again, steroids are used and surgery can be considered with mixed results. Closed head injury. Closed head injury, CHI, is the most common type of TBI and a significant cause of morbidity and mortality in the United States. There are two important factors that affect the outcome of CHI in general. The initial impact causes the primary injury, defined as the immediate injury to neurons from transmission of the force of impact. The long, delicate axons of the neurons can shear as they undergo differential acceleration or deceleration along their projecting pathways. Prevention strategies such as wearing helmets remain the best means to decrease disability from primary injury. Subsequent neuronal damage due to the sequelae of trauma is referred to as secondary injury. Hypoxia, hypotension, hydrocephalus, intracranial hypertension, thrombosis, and intracranial. 3. One focus of basic research in TBI, critical care medicine, and neurosurgical intervention is to decrease the effects of secondary injury. The Brain Trauma Foundation's most recent summary of management recommendations for TBI patients was published in 2016 and is endorsed by the American Association of Neurological Surgeons, Congress of Neurological Surgeons, and the World Health Organization. The guidelines standardize the care of these patients with the hope of improving outcomes. Level 1 recommendations are based on a body of high-quality evidence, such as large, well-received randomized controlled trials. Level 2 and 2 recommendations are based on moderate and low-quality evidence, respectively. Some of the common patterns of chi, including concussion, contusion, and diffuse axonal injury, are discussed in types of closed head injury. 11. Initial assessment. The initial evaluation of a trauma patient remains the same whether or not the primary surveyor suspects head injury. The first 3 elements of the ABCDs of resuscitation, airway, breathing, and circulation must be assessed and stabilized. Hypoxia and hypotension are known to worsen outcome in TBI due to secondary injury, making cardiopulmonary stabilization critical. Patients who cannot follow commands require intubation for airway protection and ventilatory control. The 4th element, assessment of D for disability, is undertaken next. Motor activity, speech, and eye opening can be assessed in a few seconds and a GCS score assigned. The following is an example of how a primary surveyor may efficiently assess disability in GCS. Approach the patient and enter his or her field of view. Observe whether the patient is visually attentive. Clearly command, "Tell me your name." Then ask the patient to lift up 2 fingers on each side sequentially and wiggle the toes. A visually or verbally unresponsive patient should be assessed for response to peripheral stimuli such as nail bed pressure or deep central painful stimulation such as a firm twisting pinch of the sensitive supraclavicular skin. Watch for eye opening and movement of the extremities, whether purposeful or reflexive. Assess the verbal response. A visually or verbally unresponsive patient should be assessed for response to peripheral stimuli such as nail bed pressure or deep central painful stimulation such as a firm twisting pinch of the sensitive supraclavicular skin. Watch for eye opening and movement of the extremities, whether purposeful or reflexive. Assess the verbal response. The motor, verbal, and eye-opening scores may be correctly assigned using this rapid examination. An initial assessment of the probability of significant head injury can be made, assuming that pharmacologic and toxic elements have not obscured the examination. The surveyor must also take note of any external signs of head injury, including bleeding from the scalp, nose, or ear, or deformation of the skull or face. Classification TBI can be classified as mild, moderate, or severe. For patients with a history of head trauma, classification is as follows. Severe head injury if the GCS score is 3 to 8, moderate head injury if the GCS score is 9 to 12, and mild head injury if the GCS score is 13 to 15. Many patients present to emergency rooms and trauma bays with a history of TBI. A triage system must be used to maximize resource utilization while minimizing the chance of missing a colt or progressing injuries. TBI patients who are asymptomatic, who have only headache, dizziness, or scalp lacerations, and who did not lose consciousness have a low risk for intracranial injury and may be discharged home without a head CT scan. Head-injured patients who are discharged should be sent home with reliable family or friends who can observe the patient for the first post-injury day. Printed discharge instructions, which describe monitoring for confusion, persistent nausea, weakness, or speech difficulty, should be provided to the caretaker. The patient should return to the emergency department for evaluation of such symptoms. Patients with a history of altered consciousness, amnesia, progressive headache, skull or facial fracture, vomiting, or seizure have a moderate risk for intracranial injury and should undergo a prompt head CT. If the CT is normal and the neurologic examination has returned to baseline, excluding amnesia of the event, then the patient can be discharged to the care of a responsible adult, again with printed criteria for returning to the emergency room. Otherwise, the patient must be admitted for a 24-hour observation period. Patients with depressed consciousness, focal neurologic deficits, penetrating injury, depressed skull fracture, or changing neurologic examination have a high risk for intracranial injury. These patients should undergo immediate head CT and admission for observation or intervention as needed. Types of closed head injury. Concussion. A concussion is defined as temporary neuronal dysfunction following non-penetrating head trauma. The head CT is normal, and deficits resolve over minutes to hours. Definitions vary. Some require transient loss of consciousness, while others include patients with any alteration of mental status. Memory difficulties, especially amnesia of the event, are very common. Concussions may be graded. One method is the Colorado grading system. Head trauma patients with confusion only are grade 1. Patients with amnesia are grade 2, and patients who lose consciousness are grade 3. Studies have shown that the brain remains in a hypermetabolic state for up to a week after injury. The brain is also much more susceptible to injury from even minor head trauma in the first 1 to 2 weeks after concussion. This is known as second impact syndrome, and patients should be informed that even after mild head injury, They might experience memory difficulties or persistent headaches. Return to play guidelines after sports-related concussions are controversial and are under active debate. Contusion. A contusion is a bruise of the brain and occurs when the force from trauma is sufficient to cause breakdown of small vessels and extravasation of blood into the brain. The contused areas appear bright on CT scan, as seen in figure 42.8. The frontal, occipital, and temporal poles are most often involved. The brain sustains injury as it collides with rough, bony surfaces. Contusions themselves rarely cause significant mass effect as they represent small amounts of blood in injured parenchyma rather than coherent blood clots. Edema may develop around a contusion, causing mass effect. Contusions may enlarge or progress to frank hematoma, particularly during the first 24 hours. Contusions also may occur in brain tissue opposite the site of impact. This is known as a contre-coup injury. These contusions result from deceleration of the brain against the skull. Diffuse axonal injury. Diffuse axonal injury is caused by damage to axons throughout the brain due to rotational acceleration and then deceleration. Axons may be completely disrupted and then retract, forming axon balls. Small hemorrhages can be seen in more severe cases, especially on MRI. Figure 42-8. Severe bilateral contusions in the basal aspect of the frontal lobes caused by the brain moving over the rough, irregular skull base during sudden cranial acceleration. Hemorrhage is classically seen in the corpus callosum and the dorsolateral midbrain. DIE can be considered to be a severe form of a concussion, often with irreversible consequence. It can often explain a poor neurological examination, such as impaired arousal, in cases without clear radiographic signs of global brain injury, particularly when there is damage in structures, such as the pontine reticular activating system or bilateral thalami that are necessary for arousal. In these cases, alternative explanations of poor arousal, such as a basilar thrombus, must also be investigated. Penetrating injury. These injuries are complex and must be evaluated individually. The two main subtypes are missile EG due to bullets or fragmentation devices and non-missile EG due to knives or ice picks. Some general principles apply. If available, skull x-rays and CT scans are useful in assessing the nature of the injury. Cerebral angiography must be considered if the object passes near a major artery or dural venous sinus. Operative exploration is necessary to remove any object extending out of the cranium, as well as for debridement, irrigation, hemostasis, and definitive closure. Small objects contained within brain parenchyma are often left in place to avoid iatrogenic secondary brain injury. High-velocity missile injuries from high-powered hunting rifles or military weapons are especially deadly because the associated shock wave causes cavitary tissue destruction of an area that is much larger than the projectile itself. Projectiles that penetrate both hemispheres or traverse the ventricles are almost universally fatal. Antibiotics are given to decrease the chances of meningitis or abscess formation. However, the evidence supporting the use of antibiotics following missile injury is weak and largely comes from retrospective case studies and expert opinion. Recent guidelines published in regard to preventing combat-related infections recommend antimicrobial therapy for 5 days or until resolution of the associated CSF leak, albeit with limited supporting evidence. Traumatic intracranial hematomas. The various traumatic intracranial hematomas contribute to death and disability secondary to head injury. Hematomas can expand rapidly and cause brain shift and subsequent herniation. Emergent neurosurgical evaluation and intervention often are necessary. Epidural hematoma EDH is the accumulation of blood between the skull and the dura. EDH usually results from arterial disruption, especially of the middle meningeal artery. The dura is adherent to bone, and some pressure is required to dissect between the two. On head CT, the blood clot is bright, biconvex in shape lentiform, and has a well-defined border that usually respects cranial suture lines. An EDH is typically found over the convexities, but may rarely occur in the posterior fossa as well. EDH has a classic 3-stage clinical presentation that is probably seen in only 20% of cases. The patient is initially unconscious from the concussive aspect of the head trauma. The patient then awakens and has a lucid interval, while the hematoma subclinically expands. As the volume of the hematoma grows, the decompensated region of the pressure volume curve is reached. ICP increases, and the patient rapidly becomes lethargic and herniates. Uncal herniation from an EDH classically causes ipsilateral third nerve palsy and contralateral hemiparesis. Open craniectomy for evacuation of the congealed clot and hemostasis generally is indicated for EDH. In some cases, EDH can be caused from bony venous bleeding that is self-limited. 1838. Who meet all the following criteria. 1838. Who meet all the following criteria may be managed conservatively. Clot volume less than 30 centimeters, maximum thickness less than 1.5 centimeters, and GCS score greater than 8.10. Prognosis after successful evacuation is better for EDH than subdural hematoma, SDH. EDHs are associated with lower energy trauma with less resultant primary brain injury. Good outcomes may be seen in 85% to 90% of patients with rapid CT scan and intervention. In some cases, EDH can also be caused by dural venous sinus tears that rapidly expand and are typically associated with a high degree of morbidity when treated surgically. Acute subdural hematoma. An acute SDH is the result of an accumulation of blood between the arachnoid membrane and the dura. Acute SDH usually results from venous bleeding, typically from tearing of a bridging vein running from the cerebral cortex to the dural sinuses. The bridging veins are subject to stretching and tearing during acceleration, deceleration of the head because the brain shifts in relation to the dura, which firmly adheres to the skull. Elderly and alcoholic patients are at higher risk for acute SDH formation after head trauma due to brain atrophy. On head CT scan, the clot is bright or mixed density, crescent-shaped, lunate, may have a less distinct border, and does not cross the midline due to the presence of the falx. Most SDHs occur over the cerebral hemispheres, but they may also occur between the hemispheres or layer over the tentorium. Open craniotomy for evacuation of acute SDH is indicated for any of the following: thickness greater than 1 centimeter, midline shift greater than 5 millimeters, or GCS drop by 2 or more points from the time of injury to hospitalization. Non-operatively managed hematomas may stabilize and eventually reabsorb or evolve into chronic SDHs. This management requires frequent neurologic examinations until the clot stabilizes based on serial head CT scans. The prognosis for functional recovery is significantly worse for acute SDH than EDH because it is associated with greater primary injury to brain parenchyma from high-energy impacts. Prompt recognition and intervention minimizes secondary injury. The elderly patients with low admission GCS or high postoperative ICP do poorly, with as few as 5% attaining functional recovery. Chronic subdural hematoma, chronic SDH, is a collection of blood breakdown products that is at least 2 to 3 weeks old. Acute hematomas are bright white hyperdense on CT scan for approximately 3 days, after which they fade to isodensity with brain and then to hypodensity after 2 to 3 weeks. A true chronic SDH will be nearly as dark as CSF on CT. Traces of white are often seen due to small recurrent hemorrhages into the collection. These small bleeds may expand the collection enough to make it symptomatic. This phenomenon is referred to as an acute on chronic SDH. Figure 42-9 demonstrates the CT appearance of an acute on chronic SDH. Vascularized membranes form within the hematoma as it matures. These membranes may be the source of acute hemorrhage. Chronic SDHs often occur in patients without a clear history of head trauma, as they may arise from minor head injury. Alcoholics, the elderly, and patients on anticoagulation are at higher risk for developing chronic SDH. Patients may present with headache, seizure, confusion, contralateral hemiparesis, or coma. A chronic SDH greater than 1 centimeter or any symptomatic SDH should be surgically drained. Unlike acute SDH, which consists of a thick, or figure 42-9, head-computed tomography scan of an elderly patient with progressing left hemiplegia and lethargy, demonstrating an acute on chronic subdural hematoma. History revealed that the patient sustained a fall 4 weeks before presentation. Arrowheads outline the hematoma. The acute component is slightly denser and is seen as the hyperdense area in the dependent portion. Congealed clot. Chronic SDH typically consists of a viscous fluid with the texture and dark brown color reminiscent of motor oil, or a simple burr hole can effectively drain most chronic SDHs. However, the optimal treatment of chronic SDH remains controversial. Recent data suggests that open craniotomy is effective at reducing recurrence, but may be associated with more short-term complications. Most authorities agree that burr hole drainage should be attempted first to obviate the risks of formal craniotomy. A single burr hole placed over the dependent edge of the collection can be made, and the space is copiously irrigated until the fluid is clear. A second, more anterior burr hole can then be placed if the collection does not drain satisfactorily due to containment by membranes. The procedure is converted to open craniotomy. If the SDH is too congealed for irrigation drainage, the complex of membranes prevents effective drainage, or persistent hemorrhage occurs that cannot be reached with bipolar cautery through the burr hole. The required surgical prepping and draping are always performed to allow simple conversion to craniotomy, and the scalp incision and burr holes are placed to allow easy incorporation into larger skin flaps. There are various strategies to prevent reaccumulation of blood. Subdural or subgaleal drains may be left in place for 1 to 2 days. Subdural drains have been shown to reduce the risk of recurrence, whereas corticosteroid use in this patient population has been associated with higher morbidity without benefit. Mild hydration and bed rest with the head of the bed flat may encourage brain expansion. High levels of inspired oxygen may help draw nitrogen out of the cavity. Regardless of the strategy used, follow-up head CT scans are required postoperatively and approximately 1 month later to document resolution. Intraparenchymal hemorrhage, isolated hematomas within the brain parenchyma are most often associated with hypertensive hemorrhage or arteriovenous malformations, AVMs. Bleeding may occur in a contused area of brain. Mass effect from developing hematomas may present as a delayed neurologic deficit. Delayed traumatic intracerebral hemorrhage is most likely to occur within the first 24 hours. Patients with contusion on the initial head CT scan should be reimaged 24 hours after the trauma to document stable pathology. Indications for craniotomy include any clot volume greater than 50 centimeters or a clot volume greater than 20 centimeters with referable neurologic deterioration, GC6-8, an associated midline shift greater than 5 millimeters or basal cistern compression. Pneumocephalus, or air in the intracranial cavity, is commonly seen in neurosurgical patients following head trauma or following intracranial surgery. Pneumocephalus requires a defect in the skull that allows air to enter the intracranial cavity. This may represent an iatrogenic defect created following cranial surgery or following head trauma. Approximately 66% of post-craniotomy CT scans demonstrate some extent of pneumocephalus. The identification of pneumocephalus following head trauma can offer important clues about the extent of injury, such as the presence of skull-base fractures or a CSF leak. In rare cases, pneumocephalus can also be seen in association with skull-base tumors or infections. Attention pneumocephalus occurs when the intracranial air pocket is under tension, which can result in life-threatening herniation if left untreated. This is a neurosurgical emergency and requires an urgent neurosurgical consultation. 2 radiographic features have been associated with attention pneumocephalus figure 4210. First, the Mount Fuji sign, where the air pocket separates the frontal lobes and widens the interhemispheric fissure, mimicking the silhouette of Mount Fuji. Second, the air bubble sign, where there are multifocal pockets of air throughout the subarachnoid cisterns, putatively within the subarachnoid space. These radiographic findings are helpful clues, however. The diagnosis of tension. Pneumocephalus also requires a worsening neurological exam consistent with increased intracranial pressure and impending herniation. A burr hole may be, figure 42-10. CT image on left illustrates Fuji sign arrowhead and intraparenchymal air arrow. CT image on R illustrates brain herniation into the ethmoid sinus arrowhead, used to relieve intracranial pressure per the discretion of the neurosurgical team. When not associated with tension dynamics, the clinical significance and management of pneumocephalus depends on the underlying mechanism. There are thought to be 2 major mechanisms by which pneumocephalus develops. First, the ball valve mechanism involves the passage of air into the intracranial cavity during periods of positive pressure, whereby the defect in the skull acts as a one-way valve. In these cases, management involves avoiding positive pressure ventilation and laying the head of the bed flat to minimize air traveling upwards into the cranial cavity. Second, the inverted bottle mechanism involves air entering the intracranial space due to a negative pressure gradient created by the drainage of CSF. In most cases, drainage occurs through a traumatic or iatrogenic CSF leak, but it may also occur through ventricular or lumbar drainage. In these cases, management should be focused on minimizing CSF drainage through the defect. If the CSF leak is at the skull base, as is the case following basilar skull fractures or those involved in the mastoid air cells, then the head of bed must be elevated so as to reduce hydrostatic pressure in the ventricular CSF fluid column. And controlled CSF diversion can be performed using an extraventricular or lumbar drain. See skull fractures for further discussion. Definitive repair of the skull base defect can also be considered, but this is often done on an elective basis. In general, non-tension pneumocephalus will resolve on its own with time as it is resorbed into the bloodstream. Supplemental 100% oxygen may be used to increase the rate of resorption by increasing the diffusion gradient of nitrogen predominant intracranial air pocket and the bloodstream. Management of traumatic brain injury. General medical management, several medical steps may be taken to minimize secondary injury and the systemic consequences of head injury. Patients with a documented chi and evidence of intracranial hemorrhage or a depressed skull fracture should receive a 1 gram Keppra loading dose, followed by 1 week of therapeutic maintenance Keppra, typically 500 milligrams twice a day. Anti-seizure prophylaxis has been shown to decrease the incidence of early post-traumatic seizures. There is no evidence to support long-term use of prophylactic anti-epileptic agents. Even though the clinical studies supporting early anti-seizure prophylaxis use phenytoin, Keppra is typically used in clinical practice due to a more favorable side effect profile. Blood glucose levels should be closely monitored by free blood sugar checks and controlled with sliding scale insulin. Fevers also should be evaluated and controlled with antipyretics as well as source-directed therapy when possible. Hyperglycemia and hyperthermia are toxic to injured neurons and contribute to secondary injury. Head-injured patients have an increased prevalence of peptic ulceration and GI bleeding. Peptic ulcers occurring in patients with head injury or high ICP are referred to as Cushing's ulcers. Ulcer prophylaxis should be used. Compression stockings or athrombic pumps should be used when the patient cannot be mobilized rapidly for prophylaxis of deep venous thrombosis. Steroids and traumatic brain injury per level 1 recommendation, high quality evidence from the Brain Trauma Foundation. Steroids are not recommended for the management of TBI or reduction of elevated ICP. Also, high dose methylprednisolone is contraindicated in severe TBI. A large randomized controlled trial crash equal to 9,673 6-month follow-up. 1,840 TBI GCS38 that received methylprednisolone as compared to placebo. This effect was also present when analyzing TBI of all severity levels. Blood pressure management in TBI is a complex issue. On one hand, hypotension results in hypoperfusion that may worsen brain injury that occurs following TBI. On another hand, hypertension may result in expansion of intracranial hematomas that are often seen in TBI. There is clear evidence from retrospective studies that frank hypotension SPP less than 90 mmHg is associated with increased mortality in TBI, particularly in the pre-hospital setting and during resuscitation. A large retrospective cohort study in equal to 15,733 identified hypotension thresholds that were associated with an increased risk of mortality in patients with TBI of varying age. Based on these data, the Brain Trauma Foundation guidelines provide a level 3 low-quality recommendation that maintaining systolic blood pressures greater than 101 mmHg ages 50-69 years, or greater than 110 ages 15-49 years, or greater than 70 years may be considered to reduce mortality and improve outcomes. More recently, a large retrospective study demonstrated a dose-dependent relation between the duration of prehospital hypotension and increased mortality in patients with TBI, such that a 10-point increase in systolic blood pressure across a broad range, 4,119 mmHg, was associated with an 18.8% decrease in adjusted odds of in-hospital mortality. These results suggest that having a single hypotension threshold may not be sufficient in management of TBI and may require more aggressive management than currently employed. Furthermore, an important and underappreciated consideration in blood pressure management is the baseline blood pressure of the patient. Future studies should assess blood pressure management goals that are tailored to each individual patient's baseline blood pressure. On the other hand, hypertension in TBI may have implications for intracranial hematoma expansion. It is common in clinical practice to recommend that systolic blood pressures are maintained less than 160 mmHg to mitigate the risk of hematoma expansion. Evidence supporting this practice is largely extrapolated from non-TBI patients. A small retrospective study in equal to 6932 demonstrated an increased risk of postcraniotomy intracranial hematoma in patients with intraoperative hypertension, 62% against 34% controls, P less than 0.001, and postoperative hypertension in the first 12 hours after surgery, 62% against 25% controls, P less than 0.001. A recent large retrospective study in patients with anticoagulant-associated intracranial hematoma demonstrated that lowering SBP to less than 160 mmHg within 4 hours of admission was associated with a reduced risk of hematoma expansion in equal to 691, 33.1%, less than 160 mmHg against 52.4% in greater than or equal T160 mmHg P lieutenant. However, there are no specific recommendations from the Brain Trauma Foundation on a hypertension threshold to avoid in patients with traumatic intracranial hematoma. Anticoagulation reversal in prophylaxis patients with intracranial hematoma who are on anticoagulation for cardiovascular indications, atrial fibrillation, cardiac stents, or mechanical valves or stroke prevention present a challenging population. Anticoagulation reversal is important to reduce the risk of hematoma expansion. However, anticoagulant reversal is also associated with thrombotic cardiovascular complications. A recent retrospective study in patients with non-traumatic oral anticoagulant-associated intracranial hematoma showed that lowering the INR to less than 1.3 within 4 hours of admission was an independent predictor of hematoma expansion and equal to 853, 19.8% against 41.5% in NR of greater than or equal to 1.3 PLT. Furthermore, this study showed that the risk of ischemic complications was greater in patients that were not restarted on oral anticoagulation as compared to those that were subsequently restarted and equal to 719. 5.2% against 15%, no restart, P less than 0.001. However, they did not observe a significant increase in the risk of hemorrhage with anticoagulation restart, equal to 719, 8.1% against 6.6%, P equal to 0.48. The median time to anticoagulation restart was 30 days after discharge, interquartile range 1865. As such, these data do not speak to risks and benefits of restarting anticoagulation in the acute post-bleed interval. It is important to note that the risks and benefits of restarting anticoagulation will vary based on the individual patient and the patient's indications for anticoagulation, e.g., mechanical heart valve against atrial fibrillation. As such, close collaboration between the neurosurgery and cardiology teams are important in optimizing a management strategy for these patients. Anticoagulation prophylaxis for prevention of venous thrombosis also involves a risk-benefit analysis. Per Level 2 low-quality recommendation of Brain Trauma Foundation guidelines, anticoagulation prophylaxis with low molecular weight heparin or low-dose unfractionated heparin may be used to reduce the risk of venous thrombosis, even though it is associated with an increased risk of intracranial hematoma expansion. It may be reasonable to initiate prophylactic anticoagulation 24 hours after an intracranial hematoma is deemed to be stable. A single-center retrospective study in equal to 236 found that such a strategy was associated with a decreased risk of DVT 0% against 5.6% in equal to 6, P less than 0.001, but did not observe significant differences in the rates of pulmonary embolism 0.78% and equal to 1 against 3.74% and equal to 4, P equal to 0.18, or intracranial hematoma expansion 0.7% against 2.8%, P equal to 0.3. However, because of the low rate of clinical events observed in this series, the study may have been underpowered to identify small differences in pulmonary embolism or hematoma expansion. Indications for invasive intracranial monitoring in patients with severe TBI GCS less than 8. The Brain Trauma Foundation guidelines endorse a level IIB recommendation, low quality of evidence for ICP and cerebral perfusion. Pressure, CPP, to reduce short-term mortality within 2 weeks of hospitalization. They also provide level IIB recommendations for treating ICP greater than 22 mmHg and treating CPP level between 60 and 70 mmHg to optimize outcomes. These recommendations are supported by a recent retrospective cohort study in equal to 459.34 that identified ICP and CPP thresholds that best discriminated between survivors and non-survivors in severe TBI, and also between survivors with poor and favorable outcomes. Glasgow Outcome Scale 1-3 against 4-6. A large multi-center randomized controlled trial performed in 6 hospitals in Ecuador and Bolivia did not support the claim that intracranial monitoring in severe TBI results in improved clinical outcomes. Chestnut et al. In 2012 did not observe a significant difference in mortality or favorable outcomes as assessed by the Glasgow Outcome Scale when severe TBI patients were managed with an intracranial monitor N equal to 56 or with imaging and clinical exam equal to 53, P equal to 0.43. Advanced multimodal monitoring, such as brain tissue oxygen PbRO2 monitoring, jugular bulb monitoring of arteriovenous oxygen content difference, ABDO2, cerebral autoregulation with TCD, and microdialysis are under active investigation. Only jugular bulb monitoring of ABDO2 is associated with a level 3 poor quality evidence recommendation to guide management in severe TBI. The brain tissue oxygen monitoring and TBI boost trials are actively investigating the added benefit of brain tissue oxygenation beyond intracranial pressure monitoring in severe TBI. Decompressive craniectomy. For severe TBI, decompressive craniectomy can be performed to relieve intracranial pressure associated with diffuse cerebral edema in cases of severe TBI without mass lesions, e.g. extraaxial hematoma. This is a controversial issue as there is a paucity of high-quality evidence providing clear support for or against this intervention. The DECRA trial, a multi-center randomized controlled trial, N equal to 155, compared bifrontal decompressive craniectomy to medical management for the treatment of patients with severe TBI and elevated intracranial pressure. Refractory to first-tier therapies, ICP greater than 220 mmHg for at least 15 minutes within an hour. They found no significant difference in mortality at 6 months and found that functional outcomes as measured by the extended Glasgow Outcome Scale were worse in patients who underwent surgery. They found a clear improvement in ICP, a number of days in the ICU in patients that underwent surgery, as compared to medical management. Of note, they used an intention to treat analysis such that 18% of patients in the medical management group underwent a delayed craniotomy as a life-saving procedure. More recently, the Rescue ICP trial, a multi-center randomized control trial, N equal to 408, compared decompressive craniotomy and ongoing medical care in patients with severe TBI without mass lesions with elevated ICP greater than refractory to first and second tier interventions, medical management, and ventriculostomy. Patients were randomized to either receive a barbiturate infusion medical group or undergo decompressive craniotomy surgery group. Unilateral hemicraniectomy against bifrontal craniotomy, depending on degree of bilateral swelling and surgeon discretion. Again, they used an intention to treat analysis such that 37% of patients of the medical group underwent decompressive hemicraniectomy. At 6 months, decompressive craniectomy in patients with traumatic brain injury and refractory intracranial hypertension resulted in lower mortality and higher rates of vegetative state, lower severe disability, and upper severe disability than medical care. The rates of moderate disability and good recovery were similar in the two groups. The recent Brain Trauma Foundation guidelines offer a level 2 moderate quality recommendation against performing a bifrontal decompressive hemicraniectomy to improve functional outcomes at 6 months in patients with severe TBI with diffuse injury and no mass lesions and with elevated ICP that is medically refractory. They note that this procedure has been demonstrated to reduce time in the ICU and ICP. However, they have not made an updated recommendation since the results of the Rescue ICP trial have been published. The results of the DECRA and Rescue ICP trials suggest caution and careful consideration prior to performing decompressive craniotomy in treating severe TBI without mass lesions. There is now evidence that this procedure can be life-saving and reduce mortality at 6 months, however. It is not clear that the survivors have a favorable functional outcome, as grossly measured by the extended Glasgow. Vascular injury, trauma to the head or neck may cause damage to the carotid or vertebrobasilar systems. Generally, dissection refers to violation of the vessel wall intima. Blood at arterial pressures can then open a plane between the intima and media, within the media, or between the media and adventitia. The newly created space within the vessel wall is referred to as the false lumen. Tissue or organs supplied by dissected vessels may subsequently be injured in several ways. Expansion of the hematoma within the vessel wall can lead to narrowing of the true vessel lumen and reduction or cessation of distal blood flow. Slow flowing or stagnant blood within the false lumen exposed to thrombogenic vessel wall elements may thrombose. Pieces of thrombus may then detach and cause distal embolic arterial occlusion. Also, the remaining partial thickness vessel wall may rupture, damaging adjacent structures. Traumatic dissection may occur in the carotid artery anterior circulation or the vertebral or basilar arteries posterior circulation. Dissections may be extradural or intradural. Intradural dissection can present with subarachnoid hemorrhage, SA. Traditional angiography remains the basis of diagnosis and characterization of arterial dissection. Angiographic abnormalities include stenosis of the true lumen or string sign, visible intimal flaps, and the appearance of contrast in the false lumen. 4-vessel cerebral angiography should be performed when suspicion of dissection exists. Historically, patients with documented arterial dissection have been anticoagulated with heparin and then warfarin to prevent thromboembolic stroke. Trauma patients often have concomitant absolute or relative contraindications to anticoagulation, complicating management. Antiplatelet therapy is often implemented in lieu of full anticoagulation. However, there is no randomized clinical trial comparing the two therapies. Consider surgical or interventional techniques for persisting embolic disease and for vertebral dissections presenting with SHH. Surgical options include vessel ligation and bypass grafting. Interventional radiology techniques include stenting and vessel occlusion. Occlusion techniques require sufficient collateral circulation to perfuse the vascular territory previously supplied by the occluded vessel. Carotid dissection. Carotid dissection may result from neck extension combined with lateral bending to the opposite side, or trauma from an incorrectly placed shoulder belt tightening across the neck in a motor vehicle accident. Extension or bending stretches the carotid over the bony transverse processes of the cervical vertebrae, while seatbelt injuries cause direct trauma. Symptoms of cervical carotid dissection include contralateral neurologic deficit from brain ischemia, headache, and ipsilateral Horner syndrome from disruption of the sympathetic tracts ascending from the stellate ganglion on the surface of the carotid artery. The patient may complain of a traumatic vessel wall injury to the portion of the carotid artery running through the cavernous sinus may result in a carotid cavernous fistula CCF. This creates a high-pressure, high-flow pathophysiologic blood flow pattern. CCFs classically present with pulsatile proptosis, the globe pulses outward with arterial pulsation, retroorbital pain, and decreased visual acuity or loss of normal eye movement due to damage. 1,842 earnest sinuses. Symptomatic CCF should be treated to preserve eye function. Fistulae may be closed by balloon occlusion using interventional neuroradiology techniques. Fistulae with wide necks are difficult to treat and may require total occlusion of the parent carotid artery.